Next topic will be presented by Mario from Mayo Clinic. The topic will be Mayo Clinic thyroid RF ablation experience. Dr. Stan, please.
Thank you, and good morning to everybody. I have been charged, as you see, to describe what is happening currently at Mayo Clinic with the RFA, thyroid RFA, and I will start by acknowledging that we don't have any disclosure in this field. These are the objectives that I aim to go over with you and basically discuss what is the current standard of practice regarding thyroid nodules, including those toxic ones. Look a little bit at how we got where we are with the RFA at Mayo and what are some of the projects that we have going on. But before we go into this pathway, I would like to make actually one disclosure and at the same time acknowledge Dr. Valcavi in a more unusual way. Let me tell you that I have done 0 RFA procedures. And actually, I intend to keep that number. So I'm an endocrinologist. I see, or what you might call a thyroidologist. I see thyroid disease day in and day out. And there's 10 of us at Mayo Clinic that form this thyroid core group. So we see these patients. And about 10 years ago, a very nice lady in her early 50s came to see me. And she was very uncomfortable about her goiter. And I discussed with her the standard management for a goiter, and she did not want to consider anything surgical or radioactive iodine. So I was reading about Dr. Valcavi's studies with, I don't remember if it was laser or RFA at the time, laser. So I said, you know, you could get in touch with this guy and see if he can help you, but we don't do that here. So she did, and I've seen this lady about 12 months later. And 1, she was very happy. But 2, I was blown away by how her neck looked. And this was a lady that was paying a lot of attention to her attire, but she was always wearing a scarf. Summertime, all the time, she was very concerned about her neck. When I saw her back, her neck looked almost perfectly symmetric. It was a huge difference. So then I got to my team and I said, this is something that we need to learn about. This is something that we need to pursue. And as I said, there's a group of us, and so happens I'm the chair of that group, so I had a little bit of traction. We got to our RFA team, which exists at Mayo for all soft tissue tumors. And they've done probably thousands by now, and it's mainly liver, renal. Interesting enough, they also do adrenal gland lesions. And they were very interesting. So that is the background through which Dr. Valcavi, probably without knowing, fostered the initiation of thyroid RFA at Mayo Clinic. So let's go on what I have to present you about how things are happening now at Mayo. Basically, I think we all agree that the standard of care, at least those of us that are familiar with the USA practice, is that large and growing thyroid nodules are offered surgery if there's a sense of actual symptomatic nodule. Some of those are observed if there are no symptoms yet, even if they are gradually growing. Or if they are toxic nodules, then radioactive iodine is pursued. Aesthetic concerns should come into the discussion, but I have to acknowledge that it's rarely a strong decision-making factor, particularly with our insurance environment. I have to say that there are some good elements for keeping the standard of care as it is. So first of all, we care a lot about insurance in the United States, and no insurance company will deny surgery for a large compressive nodule. Also, if we do surgery, there's no need to pursue ultrasound. That nodule is gone, right? So that simplifies, in a way, our life and the patient's life. And obviously, because the nodule is done, we don't need to consider, well, we might need to go back to repeat the procedure if we've done a good surgery. But what are the downsides? In other words, is this a satisfactory approach for everybody? And I clearly think it misses the bar on some of the important points. And the most important to me, which hasn't been discussed that much lately, is the risk of hypothyroidism. In the United States right now, the issue of thyroid being responsible for weight gain and hair loss and dry skin and brain fog is really at the top of everybody's concern when you say thyroid. So if we can avoid hypothyroidism, I think that is important. And about 50% of cases that go for a lobectomy will end up with hypothyroidism. The second issue is, particularly for those of us that are more inclined to how we look and how we appear, the presence of a surgical scar, particularly for women, is an issue of concern, and I fully acknowledge that. Obviously, there are surgical complications, and if we're talking about the use of radioactive iodine, this has implications if we're talking about young women that are still at the fertility age, as well as, there are general concerns about the use of radiation. Not everybody's comfortable saying, yeah, I'll take it, no problem. Some of us are a little more concerned about what it will do. So, coming back to how we started, first I have to tell you, things don't happen fast at Mayo Clinic. We're a rather conservative place. So we had our first discussion, as I say here, in May of 2011. And we got everything lined up with protocols because this was a research approach. In December 2013, we treated the first case. We are using general anesthesia. You've seen the moving shot technique, which is the one that we are using as well. Patients are kept in the post-anesthesia recovery unit for 2 to 3 hours after the procedure, and then they are discharged same day. And because this is something that the insurance companies do not support, we felt compelled to pursue a publication. So every time a new patient would come around, we could give them this publication so they can discuss with their insurance company. This is not something that hasn't been done before, along with other articles from many of the authors here in the room. So this is our first publication from a year and a half ago, a small series. And basically, I want to point out to you that the nodules that we were treating were reasonable sized nodule. You see the medium volume there at 24 milliliters with the range of interquartile 18 to 42. How did the response go? Well, I fully acknowledge that there's a learning curve based on what I've seen here, because you see our response rate on this very early series at 45% nodule shrinkage. And that to me was not a problem. I see more impressive results here. To me, what was very appealing was that none of the patients that was treated became hypothyroid. And then, very nicely, that I see Dr. Valcavi looking at the same issue. We had a questionnaire for all patients as to what was their score before the procedure and what was it after procedure. And this is a 1 to 6 scale. They started at 3.5, and post-treatment, they were all between 0 and 1. So 1 is the median there. This was very rewarding, so we decided to keep on with this procedure. We like it, and we think it's performing well. This is a general overview. You can see every line represents a patient. Everybody had an improvement in their nodule volume. But an area that I find also appealing is the case of toxic adenoma, and we'll have a full lecture on this, I think, right after mine. We all know that this is a cause of hyperthyroidism, but some of these nodules are actually compressive. So we have a dual hit there. And the standard of care is still surgery or radioactive iodine. And we already discussed what are the downsides of those. And you see on this scintigram, we're talking about this very hot nodules with completely suppressed rest of the thyroid parenchyma. So this is our initial case of a toxic adenoma. And you see a subclinical hyperthyroidism with a suppressed TSH and normal T3 and T4, the nodule at 5.3 milliliters. What happens 6 months later, post-RFA, the reduction in this nodule actually was above the average, 75%, but this was the part that was really rewarding to us. The TSH completely normalized in 6 months. So we found that this is another valuable option for patients along with the other two that I mentioned. So where are we now if I sum up our current practice? We have a total of 50 ablations performed, out of which 44 were on non-toxic nodules. All these were benign lesions. There were 5 toxic nodules, And I'm going to talk in a few minutes about this one additional case in which actually we did not ablate a nodule, but we ablated thyroid parenchyma. And I'll tell you why. Here is the part that I still find most appealing to me as endocrinologist. The thyroid function remained normal in 100% of the non-toxic nodules. Nobody had to start levothyroxine. Few people were on levothyroxine and their dose did not change. Everybody that was euthyroid remained euthyroid. In those that had toxic adenomas, 5 of the 6 normalized their thyroid function. 1 still has subclinical hyperthyroidism, and it's on a low-dose metimazole, but we're still looking to see if that will gradually improve. The volume response, I think it's fitting with the curve that we've seen from Gilles Russ yesterday, has improved from the 45% to where we are now at 55% volume shrinkage at 6 months. And I think you've seen a lot of technical factors that affect it, and those are very well outlined by Dr. Valcavi. What are the complications? Because every time we offer a procedure, the patients are going to ask, but is there any downside? Is there any side effect? And I think it's important that both as proceduralists, but also as endocrinologists, we're very familiar with this aspect. So I put here in quotations what our RFA team tells them. And basically, they have a visit with us in endocrinology, and we make the clinical decision if this is a reasonable approach. And then they have a visit about the technical aspects of the procedure with the interventional radiologist who will decide if it's a feasible approach. So this is what they hear from the interventional radiologist. You have to think of it as potentially having same complications as a thyroid surgery. However, what actually happened? We've seen mild swelling that resolved in all, and I take the note from Dr. Valcavi, maybe considering the ice pack and the methylprednisolone. Mild pain, nothing beyond Tylenol, which I think is paracetamol. And we had also one vasovagal episode that, with observation, was kept in the hospital overnight, had full recovery of his heart rate. He was on beta blockers. So the question that Dr. Valcavi answered also was, what is the rate of regrowth? Because if we do surgery, there's no regrowth on that ipsilateral side. Might be on the contralateral side. So we had 3 out of 49 patients that did have regrowth. Now, not everybody has been followed for years, so some will probably have it in the future. One of these had repeat RFA. That was her choice, and I think it was a very good result on the second RFA. The second patient had a very rapid growth, actually, and my colleague that was seeing that patient felt compelled to repeat a biopsy. Now, I think this is a lesson at least for us, it was a lesson. The cytologist looked at those slides and said, this is suspicious for papillary thyroid carcinoma. We had a phone conversation with the cytologist. You know, this is a lesion that was ablated with radiofrequency ablation, so we expect there'll be some distortion. So, yeah, but the cytology, the nuclear features are very typical for PTC. So the patient underwent surgery. This is what you're seeing as to the nodule. This is exactly the area of the nodule that had radiofrequency ablation about 8 months earlier. And I asked the surgeon exactly how it felt, not only how it looks, because you can see this appearance, but he said it was a very gelatinous structure, almost sticky to the touch. What was the histology? It was a completely benign thyroid parenchyma. So I think for us, at least this is a lesson. As you've heard, 2 biopsies before RFA, and we do that, but the regrowth should make us all very careful. If we're going to repeat a biopsy, we might not know what to do with those results. So maybe make that decision before RFA, and after that, I don't think a repeat biopsy has value. The third case is still one that decided to observe. It's not regrowth to the full original size, or volume, I should say. And this is the 50th case in which we did not proceed to treat a nodule. Let me tell you why we decided to treat this young man. This is a 30-year-old that has idiopathic dilated cardiomyopathy. He's been struggling with this for about 5 years, maybe 6, and he is on a transplant list waiting for a transplantation. His ejection fraction is 37%. He's been on amiodarone for the 5 years at the time this evolved. And for the last year, he was thyrotoxic. Medical therapy was started and augmented, but despite medical therapy, he remained thyrotoxic. And for 3 weeks prior to coming to us, he reported significant worsening. And what you see here, he started losing weight, nauseous, vomiting, rather short of breath, a lot of tremors, and his heart rate was 110 or 120 on amiodarone, on beta blockers, methimazole, and prednisone. So he was hospitalized, and we offered him a thyroidectomy. Now, I think all of you in the audience that are surgeons realize that this is not something that any surgeon would take on easily. He is thyrotoxic, he's with a very low ejection fraction, and he's about to go into pulmonary edema without any additional stress. So what do? This is a case where we also proposed as a potential route, granted not validated, that radiofrequency ablation would destroy enough parenchyma to hopefully decrease his thyroid values. At least that's what we intended to do. And what you see here, at Mayo, everything goes through a protocol. We're not going to start because we think it looks good and sounds good. We have to go through the Internal Revenue Review Board, IRB, proposed a plan of how we're going to deal with the initial phase, when are we going to monitor the thyroid levels, and you see here steps very early, within 8 hours, 1 to 2 days, 1 to 2 weeks, and then the follow-up. So with this, I'll tell you how he described to me the phase at 3 days, 3 weeks, and 2 months after the procedure. And we're going to read all this in the interest of time, though I see I'm doing quite well there. But as you see here, this is a guy that was very short of breath. And 3 days after the procedure, he said, I feel better. The tremors are all gone. I don't feel any more palpitations. And he was starting to walk in the room. This is a guy that was sitting in bed 24 hours. At 3 weeks, he's already out of the hospital. He came to visit me. And when he came to the hospital, he was unable to go beyond half a flight of stairs without getting short of breath. Now he was going up and down the stairs without any difficulty, doing his routine activities, and again, tremors, palpitations gone. His weight has finally stabilized. And needless to say, at 2 months, we're still seeing this improvement clinically. Now, I'm starting with the comments because I'm going to show you something that actually says a different story. And I asked yesterday I asked one of the speakers, what do you think happens with the thyroid hormone values after the procedure, particularly if you ablate a large nodule? Well, take a look at what happened with his thyroid values. What you see on the top screen is the free T4 value. And you see a peak that was basically 3 times his pre-therapy value. This is something that happened within 24 hours. We monitored this daily, and it came down about 7 to 10 days after the procedure. But at the same time, he was feeling better. So thyroid hormone levels go up, at least in the laboratory, and clinically he improves. So the hypothesis that we have is that what we're measuring is not a functional hormone, but rather a distorted 3D structure that doesn't have the bioactivity that you would expect if you were to give somebody levothyroxine. Now, that's a speculation. We're doing some laboratory testing to assess the functionality of this hormone. But that's something that all of us should be aware, just like with the biopsy. If you repeat the biopsy after RFA, you're probably in a grain zone to begin with, and I'm not sure you can use it. If you test the thyroid hormone after RFA, I'm not sure how clearly you can interpret it. But the good thing on the bottom graph tells you what we did with his methimazole and prednisone. And from very high levels, methimazole at 60 milligrams, we're now down to, I think he's only on 5 milligrams, completely off prednisone, and he's euthyroid now for a number of months. So there are the challenges that I mentioned, the biochemical aspect versus the clinical response. We aim to do this through having basically mass spectroscopy, looking at the T3 and T4 values. But also we're going to use resting energy expenditure to actually measure the metabolic rate before and after the procedure, because we expect if this is real T4 action, we're going to see the metabolic rate go up. Hopefully not. Where are we going? We're going also in an area that I think all of us are thinking. Can we treat small cancers the same way we treat these nodules with radiofrequency ablation and spare a surgery? And I'm happy that we have Dr. Beck to go over this topic. We have not done any such case, but again, we are proposing internally a protocol for how this, we will select certain cases, all intraparenchymal, all less than 1.5 centimeters. What will be the time for follow-up? What kind of imaging and biochemical markers we're going to use in order to make this a reproducible endeavor. So with that, I will share with you in a summary slide, if you will, what are our ongoing questions. I have not seen yet very clear data on question number 1. What nodules are most likely to respond to RFA? Because there's a heterogeneity. And I think it'll be important to give a sense to the patient what is the likely scenario based on his or her nodule structure. Our impression is that the spongiform nodules are most likely to decrease most in volume. When to retreat? If the nodule shrinks by 80% and then it grows by 10%, is that a time to retreat? Some centers I know have reported on doing RFA on a monthly basis times 4. All our patients have been treated once, except one case that I mentioned that went for a second intervention. As Dr. Valcavi alluded to, what is the benefit for general anesthesia? Should we consider it routine in very large nodules? How to understand the biochemical versus the clinical response, what we just discussed. And I felt that listening to the talks yesterday, I've learned a lot. But there's still a lot of heterogeneity. We've heard a lot about different techniques. And then even within the same techniques, we're seeing differences in the approach, differences in power use, differences in the time devoted to each nodule. So I think that in order for the field to move forward, there's a need to consider standardization. This will be most helpful to promote this procedure outside of this group. I think studies need to include not only treated individuals, but also comparison patients. Comparison which are treated by the standard of care to understand how much benefit we're bringing in contrast to what is done routinely. And because there's a learning curve, I think it would be most useful to consider creation of centers of excellence where the volume is so high that people will reach the ideal response. And then for every insurance company, it'll be important to read something about what is the economics of that. If I pay for surgery and I'm done, is that the same if I pay for RFA? Because there's going to be subsequent ultrasound, maybe repeat in 10 to 20% and so forth. So that calculation, I think, will have extreme values, at least the way medicine is done in the United States. And without further ado, I want to thank to our team. This is a large team, as you see there, the 4 interventional radiologists, a team of nurses, study coordinators, and our 10-people thyroid core group sitting right there. You also see William and Charlie Mayo and cold weather in Rochester, Minnesota. And I take no more of your time. I'll turn it back to the chair, and I'll be available for questions. Thank you.
Thank you very much, Dr. Stan. Your experience in Mayo Clinic is very excellent, in my opinion, and your future perspective is also very nice. In the future, we should resolve these problems.
Thank you.
Okay, is there any questions or comments from the floor?
Valcavi, Italy. Congratulations first for your speech, and my comment is on FT4 increase after ablation. This is observed not only in toxic nodules, but I published as early as in 2010 a series of patients. Some of them had toxic adenomas, some of them didn't, but we observed an increase in most patients, a significant increase in FT4, and a suppression in TSH levels, which happened just exactly, you said, 1 week and fade away after 1 week. What I observed is that no patient had any complaint. So I believed that was due to the corticosteroid administration in the same time. But after listening to you, maybe you're right, and we should study whether the increase of thyroid hormones, which is transient and lasts 1 week, which is observed in most patients and even more in thyrotoxic patients, is a real phenomenon or is not. Clinically, I agree. And what else? I did one patient with the Graves' disease when I was at the hospital, but the same in Italy. We had excellent results in this patient. And so he had bilateral laser ablation. At that time I used the laser ablation, and he recovered completely, just in the case you reported. So I would like to endorse your proposal of treating maybe some special issue patients with Graves' disease. I did the procedure in 2 times because I was concerned about swelling, doing a bilateral procedure. But it's another point of view that we should consider, and another application of RFA or laser ablation or thermal ablation.
Thank you for your comments, Roberto. Indeed, I think that if I were to do again the treatment of somebody with significant thyrotoxicosis, clearly I would not offer it to a patient with known coronary artery disease. I think if there's a young individual, clearly I would beta block them up front before the RFA. And in that case, even if this increase is real, it's unlikely to be of clinical significance. But in an older individual, I don't want to find out that actually there is some bioactivity. So I would probably focus in individuals 60 and younger if I were to repeat the bilateral thyroid ablation. But nevertheless, in some cases, the risk of thyroidectomy here seemed much higher than whatever we would do with RFA, and it turned out okay. As far as, I think you had a couple other points, but they flew by. I thought they were good comments, though. Any other questions?
Any other questions?
I have a question about the criteria for choosing the patient with toxic nodules for the RFA and conventional therapy with radioactive iodine therapy, because the difference between the prices is very much. And which patient you sent for RFA?
So at this point, the radioactive iodine or surgery are offered to the patient as the standard of care. We don't say they are equal to RFA, but we clarify that the risk of hypothyroidism is what I just said. We clarify that there will be a surgical scar, which they obviously know. And in a young woman, the issue of using radioactive iodine, we clarify to them that pregnancy is not to be considered for at least 6 to 12 months. And if there's any kind of reluctance, then we say the alternative is to use radiofrequency ablation if the nodule position is so that it could be ablated well, which is our discussion with the interventional radiology team.
I don't know
So it's a comprehensive discussion, not that you go for RFA and you go for surgery.
No,
we don't
can-
make that decision.
No. You pursued a patient, yes, that you can choose this way and this way and this way. But the price is very different in the procedures, yes. And you don't have any specific criteria with the toxic nodules, yes.
We, as far as
It's
indications,
patient preference, something like
Doctors,
this.
Yeah.
excuse me, time is out, and discuss it personally.
we can talk later. Yeah.
Yes, let's move on to the third topic.